Potassium is the most common cation in the intracellular fluid, ICF. The ICF contains approximately 98% of the body's potassium, while only approximately 2% remains in extracellular fluid, ECF. Potassium plays a significant role in neuromuscular activity and helps acid-base balance. Dietary intake is usually sufficient to meet the daily requirements. Guidelines suggest most adults should consume at least 4,700 milligrams of potassium daily, but surveys show that Americans consume less than half that amount because of the typical Western diet is low in fruits and vegetables. Potassium is absorbed in the intestines and excreted by the kidneys. To maintain homeostasis in the body, serum potassium levels must be tightly controlled. Minimal changes in potassium concentration can cause major alterations in the body. Potassium performs the functions listed on this slide. The sodium-potassium pump, which is found in the cell membrane of every cell in the body, regulates the amount of potassium in the extracellular fluid space. Because the concentration of potassium is much higher in the intracellular fluid space than in the extracellular fluid space, potassium easily moves out of the cells down the concentration gradient via diffusion. The sodium-potassium pump then transports sodium and potassium ions across cell membranes against their concentration gradients. This process requires the expenditure of energy, which is provided by adenosine triphosphate, or ATP. Potassium is moved out of the extracellular fluid space and into the cells. Sodium is moved in the opposite direction. If an underlying disorder prevents the sodium-potassium pump from working properly, potential life-threatening electrolyte imbalances can occur. Potassium imbalances occur when there is a decrease or increase in the potassium content of extracellular fluid. To remember how potassium affects the body, associate low potassium levels, hypokalemia, with general hypoactivity in the body, such as deep tendon hyporeflexia, flattened T waves on the ECG, hypoactive bowel sounds or constipation, because of the reduced potassium levels slows down nerve impulses. Associate high potassium levels or hyperkalemia with general hyperactivity in the body, irritability, tall tinted T waves on the EKG, and hyperactive bowel sounds or diarrhea, because increased potassium levels speed up nerve impulses. The greatest danger related to either type of potassium imbalance is cardiac dysrhythmia, because the heart muscle, the myocardium, is highly excitable and most sensitive to changes in potassium levels. Hypokalemia, or potassium deficit, is a serum potassium level less than 3.5 milliequivalents per liter. If the potassium loss is gradual, the body can compensate for the change, and manifestations of hypokalemia may not appear until potassium loss is extreme. Consequences of hypokalemia are worsened by alkalosis and digitoxin therapy and hypocalcemia. Hypokalemia can be life-threatening because it disrupts the electrical activity in cardiac, skeletal, and smooth muscles, resulting in cardiac dysrhythmias and profound muscle weakness. Respiratory insufficiency and cardiac dysrhythmias are the most dangerous potential problems associated with hypokalemia. Hyperkalemia, or potassium excess, is a serum potassium level greater than 5 milliequivalents per liter. Hyperkalemia is dangerous because there are often no manifestations. Mild hyperkalemia is usually well tolerated. Moderate hyperkalemia can produce ECG changes. Sudden increase in serum potassium can cause severe problems at levels between 6 and 7 milliequivalents per liter, whereas gradual increases may not affect the patient until the level reaches 8 milliequivalents or greater. Severe hyperkalemia suppresses the electrical activity of the heart, causing cardiac dysrhythmias or cardiac arrest. Changes in fluid and potassium balance may result in actual or relative increases or decreases in potassium content. An actual increase or decrease in potassium occurs as a direct result of potassium gain or loss. A relative increase or decrease in potassium is most often caused by a shift in potassium between the intracellular fluid compartment and the extracellular fluid compartment. Actual hypokalemia may be caused by potassium loss or inadequate potassium intake or absorption, resulting in an actual decrease in potassium in the body. Vomiting and chronic diarrhea result in the loss of water, sodium, and potassium. Prolonged gastric suctioning removes fluid and hydrochloric acid, causing the pH of the blood to increase, or alkalosis. Diaphoresis caused by heat leads to the loss of water, sodium, and potassium as the body attempts to reduce its core temperature. Renal disease adversely affects the kidney's ability to reabsorb potassium. Hemodialysis and peritoneal dialysis lead to direct potassium loss. Elevated serum glucose levels leads to diuresis, causing potassium to be lost in the urine. Medications such as non-potassium sparing diuretics, digitalis preparations, corticoid steroids act on the kidneys to increase potassium excretion. Inadequate potassium intake or absorption, such as malnutrition, or starvation or eating disorders, such as anorexia and bulimia, or prolonged nothing by mouth status without IV replacement therapy can cause an actual decrease in potassium. Alcoholism causes decreases in absorption of potassium. Pica is the chronic ingestion of non-food materials such as animal feces, dirt, paper, laundry starch, or ice. If clay is ingested, it binds with potassium and decreases potassium absorption. Relative hypokalemia results when potassium shifts out of the extracellular fluid compartment and into the cells, resulting in a relative decrease in potassium content in the body. Excessive water intake dilutes serum potassium content of blood, aka dilutional hypokalemia. Alkalosis, an increase in the blood pH, causes potassium to move into the cells. Hydrogen ions then move out of the cells to compensate for the pH imbalance. Insulin administration for hyperglycemia causes potassium to move into skeletal muscles and hepatic cells. Intracellular shifts of potassium are often episodic and self-limited. Fluid, sodium, potassium, and other electrolytes often become trapped in areas that are inaccessible to the circulation. Actual hyperkalemia is caused by excessive potassium intake or potassium retention, resulting in an actual increase in potassium in the body. Overconsumption of potassium-rich foods, overuse of salt substitutes that contain potassium, and excess rapid IV infusion of IV solutions that contain potassium are examples of excessive intake of potassium resulting in hyperkalemia. Other reasons for hyperkalemia include acute kidney injury and chronic kidney disease result in decreased potassium excretion from the kidneys. Medications such as potassium-sparing diuretics and ACE inhibitors inhibit the excretion of potassium from the kidneys. Addison's disease occurs when the adrenal glands do not produce enough aldosterone. Aldosterone causes the kidneys to conserve sodium and excrete potassium. The lack of aldosterone leads to the excretion of sodium and the retention of potassium, thus resulting in increased serum potassium levels, hyperkalemia. Hyperkalemia may also be caused by fluid volume deficit or when potassium shifts out of the cells, resulting in a relative increase in potassium in the body. Relative hyperkalemia results when potassium is concentrated by excessive water loss or when potassium shifts out of the ICF and into the ECF, resulting in a relative increase in potassium content in the body. Vomiting and diarrhea result in water loss in the ECF, which causes potassium and other electrolytes to become concentrated. Severe burns can cause tissue damage and an increase in capillary permeability, resulting in profound dehydration. The water loss causes potassium to become concentrated, resulting in an elevation in the serum potassium level without an actual potassium gain. Surgical procedures, tissue trauma, and crush injuries cause damaged cells to release potassium into the bloodstream, break down muscle tissue, also release the protein myoglobin into the bloodstream, causing kidney damage and the retention of potassium. Metabolic acidosis or blood pH below 7.35 causes potassium to shift out of the cells in exchange for excess hydrogen ions as the body attempts to increase the blood pH. Tumor invasion destroys healthy cells, causing them to release their potassium stores into the ECF and resulting in an increase in the serum potassium level without an actual gain in potassium. The nurse should conduct a focused nursing assessment for potassium imbalance, beginning with a thorough nursing history. Interview the patient and the family members to identify any risk factors or pre-existing conditions that would contribute to potassium imbalance, such as vomiting, nasogastric suctioning, diarrhea, acute kidney injury, or other conditions associated with potassium loss or gain. The nurse should also assess the patient's ability to drink and tolerate oral fluids. Obtain a current dietary history. Inquire about the intake of potassium chloride-based salt substitutes. The nursing history should also include current medications, focusing on the use of diuretics and digoxin. Diuretic use increases the risk for potassium imbalance, and hypokalemia increases the risk of digoxin toxicity. A thorough physical assessment is necessary because potassium imbalances affect many body systems. Assess each body system, observing for manifestations of potassium imbalance. Measure and record the patient's vital signs and review the patient's laboratory data to assess for the presence of hypo or hyperkalemia. A hallmark finding of potassium imbalance is a change in the electrocardiogram. Potassium is needed to bring the cell membranes to a resting state after the heart contracts. Low potassium levels in the extracellular fluid compartment cause the strength of the electrical current across the cell membranes to increase, preventing the cell membranes of the heart from achieving a resting state. This leads to impaired cardiac conduction, which can result in premature ventricular contractions, PVCs, ventricular tachycardia, VT, ventricular fibrillation, VF, or asystole. Hypokalemia can be identified in an ECG rhythm strip by looking for the triad of ST depression, low amplitude T waves, and prominent U waves. As hypokalemia worsens, U waves increase in size, QRS complexes widen, ST segments become depressed, and T waves flatten or invert. High potassium levels in the extracellular fluid compartment cause the electrical current across the cell membranes to become sluggish, prolonging the resting state of the cell membranes of the heart. This leads to impaired cardiac conduction, which can result in ventricular fibrillation or asystole. Hyperkalemia is characterized by bradycardia, peaked tinted T waves, and ventricular fibrillation. Neurologic changes from hypokalemia include altered mental status. The patient may have short-term irritability and anxiety followed by lethargy that progresses to acute confusion and coma as hypokalemia worsens. Musculoskeletal changes include skeletal muscle weakness in response to hypokalemia. A patient may be so weak that he or she cannot stand. Hand grasps are weak, and decreased response to deep tendon reflex stimulation, or hyporeflexia, may be seen. Severe hypokalemia causes flaccid paralysis. Neuromuscular changes with hyperkalemia have two phases: skeletal muscle twitching in the early stages of hyperkalemia, and the patient may be aware of tingling and burning sensations followed by numbness in the hands and feet and around the mouth. As hyperkalemia worsens, muscle twitching changes to weakness followed by flaccid paralysis. Intestinal changes occur with hypokalemia because smooth muscle contractions in the intestinal tract are decreased, which leads to decreased peristalsis. The patient has hypoactive bowel sounds and may have nausea, vomiting, constipation, and abdominal distension. With hyperkalemia, intestinal changes include increased motility. The patient may have diarrhea, spastic colon activity. Bowel sounds are hyperactive with audible rushes and gurgles. Bowel movements are frequent and watery. Hypokalemia respiratory changes may occur due to the weakness of the muscles needed for breathing. Skeletal muscle weakness results in shallow respirations. With hyperkalemia, the respiratory muscles generally are not affected until the serum potassium reach lethal levels. Monitor the patient and the patient's serum potassium level as ordered by the healthcare provider. Pay particular attention to other electrolyte values: BUN, creatinine, and glucose level. Implement fall precautions related to muscle weakness caused by potassium imbalance. Perform a fall risk assessment. Maintain the bed in a low position with locked wheels. Remove obstacles from pathways, especially to the toilet. Monitor the environment for safety hazards, for example, torn carpet, liquid spills on the floor. Place assistive devices such as walkers and canes within the patient's reach. Use nightlights. Instruct the patient to request assistance to ambulate. Ensure the availability of the call light. Is it within reach? Assess footwear and provide appropriate footwear if necessary. Patients should be using anti-skid soles for ambulating. Keep items such as telephone, water, Kleenex within patient's reach. Request the family members remain with the patient if necessary. Position the patient to allow for close observation by staff members. Finally, Make sure to communicate the patient's fall risk during shift report and document not only your assessment, but also the interventions taken to prevent a patient injury. For mild to moderate hypokalemia, administering oral supplements is ordered by the healthcare provider to patients with serum potassium levels less than 3.5 milliequivalents but greater than 3.0 milliequivalents per liter is the usual protocol. Make sure to dilute powders in liquids in juice or other desired liquid to improve taste and prevent gastrointestinal irritation. Inform the patient that potassium has an extremely unpleasant taste. Follow the manufacturer's instructions for the amount of fluid to be used as a diluent for the preparation. The most common dilution is 20 milliequivalents of potassium per 120 milliliters or 4 ounces of fluid. Mix solutions thoroughly before administering them to the patient. Administer the liquid, capsule, or tablet potassium with food or meals to minimize gastrointestinal irritation. Do not crush tablets. Do not open capsules. Give whole. The usual treatment management for mild to moderate hyperkalemia is to limit dietary potassium, including potassium-based salt substitutes. If the patient was taking a potassium supplement, it is usually discontinued or the dose is lowered. Other medications the patient may be on that have the potential of causing hyperkalemia are discontinued or the amount per dose is decreased. K-exolate may be ordered by the healthcare provider. K-exolate is a potassium-removing resin. It works by drawing potassium into the large intestine and then removing it from the body. For severe hypokalemia, administer IV potassium as ordered to patients with serum potassium levels less than 3.0 milliequivalents per liter. IV potassium is a high alert drug. Do not administer it IV push. In the United States, a lethal dose of potassium chloride is the last of 3 drugs administered during execution by lethal injection. Potassium chloride actually causes death by stopping the heart. The replacement of potassium is done by IV slow infusion, 5 to 10 milliequivalents per hour. Never exceed 20 milliequivalents per hour under any circumstance. Rapid administration of high concentrations of potassium may cause cardiac arrest. Monitor cardiac function when infusing large amounts of potassium. Do not administer potassium intramuscularly or subcutaneously because potassium is a severe irritant. Dilute potassium before IV infusion. A dilution of no more than 1 milliequivalent per 10 milliliters of solution is recommended. Monitor the patient's IV site closely. Infiltration of potassium is painful and may cause tissue damage, followed by necrosis and sloughing. Potassium may cause severe irritation to the veins. Stop the infusion and notify the healthcare provider if the patient reports pain, even if the IV line is not infiltrated. An order for a small amount of an anesthetic agent, such as lidocaine, may be added to the infusion to relieve the discomfort. A severe hyperkalemic patient is treated in the hospital on a unit that has cardiac monitoring capabilities. If the hyperkalemic patient has diminished renal function, the serum potassium level is removed by dialysis or continuous hemofiltration. Administration of IV calcium may also be ordered to treat cardiac and skeletal muscle effects of the hyperkalemia. Another method to decrease serum potassium levels temporarily by increasing movement of potassium back into the cells is the administration of IV glucose and insulin. If the hyperkalemia is caused by acidosis, administering IV sodium bicarbonate may be ordered. The sodium bicarbonate promotes the movement of potassium from the extracellular fluid compartment back into the intracellular fluid compartment. If the patient has good renal function, the healthcare provider will usually order diuretics to increase the excretion of potassium by the kidneys. Either a loop diuretic, such as fluocinomide or Lasix, or a thiazide diuretic, such as chlorothiazide or Diuryl, may indeed be ordered. Teach the patient or caregiver the causes of potassium deficit. Teach the patient and caregiver how to identify the manifestations of potassium deficiency. Instruct the patient and family to notify the healthcare provider if the patient exhibits any manifestations of hypokalemia. Teach the patient about foods that contain potassium. Teach the patient how to prepare and take oral potassium supplements. Encourage the patient to keep appointments for laboratory studies to evaluate serum potassium levels because values can change dramatically. Even small variations in serum potassium can have major effects on the body. For the hyperkalemic patient, teach the causes of potassium excess as well as the manifestations of hyperkalemia. Teach the patient how to prevent potassium excess by avoiding foods high in potassium and salt substitutes that contain potassium. Educate the patient and family to choose low potassium foods such as eggs, apples, apricots, cherries, grapefruit, peaches, cranberries, cabbage, cauliflower, celery, eggplant, lettuce, green beans, onions, peas, and peppers. Instruct the patient to eat less red meat and more lean meats and cold water fish. Dehydration worsens hyperkalemia, so instruct the patient to drink more fluids to help excrete potassium from the body. Include medication administration and foods high in potassium in patient teaching. This slide represents some foods that are high in potassium. So for your hypokalemic patient, these would be good foods to incorporate into their diet. But for your hyperkalemic patient, these foods should definitely be avoided. Document all assessment findings and interventions per institutional policy and guidelines. Evaluate and document the patient's response to interventions and education. Vital signs should return to baseline for the patient. Cardiac rate and rhythms should return to baseline. The underlying cause of the potassium imbalance should be resolved. Serum potassium levels should be in the normal range of 3.5 to 5.0 milliequivalents per liter.